Thank you, Mr. Chairman. Thank you, panel, for your answers and for your insights. Ms. Carmody, if you find that the practices of your RAC auditor are abusive or outside the scope of the RAC statement of work, what's your recourse? And I'll ask a little more, maybe a specific question. In your case, what do you do if Health Data Insights, the RAC auditor not only for Montana but for my home state of South Dakota and 15 other states, is engaging in abusive or unauthorized auditing practices?
Right now, what we do is we talk to our senator and we appeal. Okay. And and in the beginning, we weren't as good at appealing. We weren't quite as ready as Intermountain Healthcare, and so we didn't appeal as much. We're appealing more and more. We've gotten people to come in and help us, and all we can do is appeal and continue to respond and make comments, letters to CMS about changes we'd like to see in the program, and talk to all of you.
Okay, and is the appeal to CMS?
The appeal is of the RAC, so
of the RAC.
It goes through the appeal process, so it starts with CMS and goes up the chain.
Yeah, okay. Ms. Draper, in your testimony, you expressed frustration about the volume of record requests. In your opinion, what's an appropriate amount of record requests for a RAC?
You know, if we could look at specifics in the different hospitals, when we are looking at one hospital who can be bombarded by 450 requests for records within a 45-day period, that's a significant change for our medical records, and we're shifting the care or the work that they need to do on coding and submission of the claims in the day-to-day process in order to respond to that record request. Again, if we could have a more focused area, and if they found a problematic area, then increase that scope, that would be much more helpful for us.
Okay. Mr. Rolfe, for claims that involve review of medical necessity, what's the education level of the auditors?
So the first level auditors are licensed nurses, the same practice that's being employed by commercial insurers and state Medicaid agencies and most payers throughout the system. And they are overseen and supported by physicians in multiple specialty areas that can provide them higher level clinical opinion on particular difficult cases.
And if decisions that are made on medical necessity that are made by a physician, are they reviewed by a peer physician at CGI?
Oftentimes, if there's an area that they require additional information on, that they will seek out one of their peers for that information. We also do a QA step with inter-rater reliability that on a monthly basis is reviewing the decisions of all of the auditors on staff to ensure consistency within and across the program.
Would you support a requirement that RACs have to abide by timelines for review like hospitals have for data requests?
So let me address that in a couple different ways, if I may, Senators. So currently under our statement of work with CMS, we're required to follow all timeliness guidelines for the completion of a review. If we do not, we're subject to losing our fee for that individual claim that we didn't review on a timely basis, which is the ultimate penalty. With regards to many of the time frames that have been discussed here, those involve appeals contractors that we have no responsibility for. But as we've said before, reform of the appeal system, I think, is warranted.
And what role does peer-reviewed medical literature play in the decision-making?
I think it's critical. Our physicians, our staff continue their continuing medical education, are kept up in current medical process and literature, and are provided with an electronic literature library for the most updated information in order to make their decisions.
How about evidence-based approaches?
All factors that are part of current medical practice are involved in the decision-making process on any one case.
Now, you mentioned you'd be open to a reform of the appeal process. Do you have any suggestions about how to do that? And I pose that question as well to both Ms. Draper and Ms. Carmody.
Increase the ability of contractors to participate in the third level of appeal. Add clinical judgment and review to the third level of appeal. Increase consistency in decision making so there's predictability in the regulations and the rules so that my fellow panelists know how to practice and we know how to audit.
I would concur with his last statement. but I would also add that in the appeal process, we need a greater level of medical experience in the first level of appeal. It's a great deal of wasted time, energy, and resources if we have to get to the third level of appeal before we can recoup our monies. And so why not put that level of expertise up at the front level?
Once again, I would agree with that statement. We need the consistency up front to know in the beginning that it's going to be looked at in the same way and that everybody's applying the same rules to how you bill a claim, and then getting that opinion moved up the appeal process and also speeding up the appeal process. Right now, our money and those claims are held up for a significant amount of time.
See, my time's expired. Thank you, Mr.
Thank you,
Chairman.
Senator.
Thank you.